Okay, well, we're going to go ahead and start so we can stay kind of on time. So I'd like to welcome everybody for joining us for the supports and services to turbocharge the recovery journey. I would like to start with a couple of reminders. The session is recorded and will be available on the conference platform 1 hour after the session ends. And please keep yourself muted unless we ask that you do otherwise. And make sure to join sessions live today because we will be doing a prize drawing from attendance with each session. And the conference is also offering free continuing education credits. For more information, visit the continuing education page. And now I'm excited to introduce you to our speaker today. And it is Samhsa, and I'm going to turn it over to you.
Joy, thank you so much. Good afternoon, everybody. It is really great to be here. As Joy said, my name is Samhsa. I'm a senior associate with C4 Innovations, and I'm here to talk about how to best provide supports and services to basically anybody seeking recovery, whether it's from an opioid use disorder, a bipolar disorder, homelessness, criminal justice involvement, trauma, or all of the above, because, you know, sometimes it is all of the above. So we're going to get to the good stuff momentarily. Let me do a little bit of quick housekeeping for the Opioid Response Network before we dive into the content. And I promise I'll make this painless and I'll make it quick. So the Samhsa funded Opioid Response Network actually works with communities and they assist states, organizations, and individuals by providing resources and technical assistance that, you know, addresses the challenges around the opioid crisis and stimulant use. Technical assistance is available for this, you know, supporting evidence-based prevention, treatment, and recovery. And again, the focus is typically opioid use and then stimulant use disorders. And I would even say that, you know, it's an addiction issue in this country. And the Opioid Response Network understands that and recognizes the challenges in front of us. The other really cool thing about ORN is that it does provide local experienced consultants in prevention, treatment, and recovery. And they do that to communities in order to have those sort of, you know, boots on the ground and inside information. As most of you know, that's really critical. And then each state and territory has a designated team. It's led by a regional technology transfer specialist. And that person really is an expert in implementing evidence-based practices. They're very easy to talk with. So they're awesome to chat. The folks will talk to you around almost any issue you want to bring to the table. They'll respond to your questions. They'll even help you think through whether or not this rises to technical assistance. And you can reach them through an email. You can visit them on their website. You can even call them, and the number's listed right there. And finally, the funding for the Opioid Response Network was made possible, in part at least, from the Samhsa grant number that you see on the screen. I probably don't want to read that to all of you. You can see it there. And with that, I think we can get busy. We've got a lot of stuff to cover this afternoon. So here are this session's learning objectives. And by the time we're done today, I'm hoping everybody's going to be able to explain the impact of stigma upon individuals with behavioral health challenges and the implications for treatment access and basically the overall success. Identify at least 2 best practices in engaging with and supporting individuals who are experiencing behavioral health challenges. Discuss the importance of a trauma-informed, person-centered approach when we are engaging and serving people who have behavioral health challenges. And finally, I'm hoping that everybody's going to be able to describe at least 2 wraparound services and why those services might be important in supporting an individual's recovery journey. I know it's an ambitious set of objectives, but I think I can do justice to it, and we're going to find out. Now, before we can talk about what we need to do to actually provide those services and supports to somebody who's either trying to access recovery or maintain it, we kind of first need to understand how recovery is even defined today, because it's going to matter as we think about other components that we're going to need to use, engage with, and even be aware of. Things like stigma, cultural proficiency and humility, the impact of trauma and addiction on your brain, and how these things interact to create challenges both to the person who's seeking recovery and to those of us who are really trying to treat and support them. Now, there's something that's happening with this table here that I want you to notice. And I don't normally have slides with all this text on it, but this one's important. And if you look at the first entry, it's a Samhsa definition from 2005, and I think it captures the overall spirit of how recovery was viewed over the last 50 years. Abstinence-based, and only then could you improve your health, wellness, and quality of life. Now, a couple of years later, in 2007, William White sort of kicked the doors in and kind of stormed the recovery Bastille, so to speak, by what he said. And if you notice, that although he alludes to a goal of actively managing the recovery by avoiding substance use, he doesn't require abstinence as part of that definition. And I can tell you all now that in 2007, this must have been close to like biblical heresy, because Bill is he's lucky he wasn't, hung out to dry for that perspective back then, because I still encounter a sizable number of folks who haven't yet received this really important message that recovery doesn't have to include abstinence from all drugs, just the illegal ones. And the table above stops at 2017 with an evolving recovery perspective from the Recovery Research Institute. And even since then, there's been some additional evolution to the overall definition. And I've heard that Samhsa's actually, kind of considering revisiting this definition again too. Their definition, Samhsa's, is a process of change through which individuals improve their health and wellness, they live a self-directed life, and they strive to reach their full potential. Individuals will achieve this by paying attention to, and there's a lot of hard work that's also involved, but it's all within these four domains: health, home, community, and purpose. Now, most of us operate under this definition and understanding of recovery today, and there are certainly others, and some I even find a little bit better, but this definition is important because it carries the weight of Samhsa, and it was developed in conjunction with the voices and the input of people who are in recovery. And I want you to notice again that abstinence is not included in this definition. And where it is mentioned, it's a very nuanced mention. It's specific to alcohol, non-prescribed medications, and illicit drugs. And if you're wondering why Samhsa decided to eliminate abstinence from the definition, one of the primary reasons was really to reduce the stigma associated with evidence-based approaches like medication-assisted treatment. Because MAT is by far the most effective evidence-based treatment available for an opioid use disorder. And many who have either used it or are currently using MAT, whether it's buprenorphine, methadone, or naltrexone, those folks are now living a self-directed life, actualizing their full potentials today. And while we may see them as not completely drug-free within their body, they are free of, and they are abstaining from, the use of illegal and non-prescribed medications, both of which usually cause them great harm and problems in the past. And if you're wondering why it is that Samhsa concerns themselves so deeply with stigma that they purposefully developed a recovery definition that doesn't require abstinence, let me show you why. Now, one other thing I want to just share before I jump into this slide, as we move through this presentation today, I've got a bunch of handouts, and I'll alert you to each one as we progress through this discussion. They're not, you don't need them for the session right now, but they are really good resources. They're 99% cutting edge and brand new. And I think you'll find them valuable long after I'm gone, okay? I'll let you know each time there's a particular handout. And for this one, there's a handout called Identifying, Deconstructing, and Reducing Stigma, and it's a toolkit. Now, I'm going to stick with MAT here as an example for stigma. It's something those who have an opioid use disorder have to deal with, and they've been dealing with it for decades. And really, even today, with folks dying like flies around us as a result of opioids, there's still a lot of folks who just don't understand MAT, and they feel that using it is a failure or a cop-out of some sort. Some of the objections that I've heard include the sort of false and misleading belief that MAT is a crutch. I've heard it called liquid handcuffs. A lot of folks think that MAT users aren't in recovery. They're just replacing one drug with another. Some folks are simply treading water rather than actually recovering from their substance use disorder. And we can't forget the impact of peer and family pressure. Both of those play significant roles in reinforcing the self-stigma. And in the SUD world, we've been stigmatizing, ostracizing, jailing, ignoring, marginalizing, restricting, shaming, guilting, beating up on, and honestly, even killing people who have a substance use disorder. We've been doing that for about the last 70 years. So individuals hiding their dirty little secret of addiction, well, they keep it that way because they have been harassed and they've been persecuted, at times unmercifully. And for some, that persecution has gone on for a long time, like decades. The vast majority of drug users already have a lot of shame and guilt for their action. So if you don't know their history, you can't shame them and you can't hold them accountable. Stigma towards those who use illegal substances is so bad that when the World Health Organization did a study of 18 of the most stigmatized social problems in 14 different countries, drug addiction ranked number 1, alcohol ranked number 2. And additional stigma comes from the way, because as drug users, folks are often also associated with like really poor mental and physical health. These assumptions are often incorrect, but that stigma is really powerful. It's sneaky and it's adaptive. And because of these sort of painful and actually really shaming, stigmatizing experiences, often occurring multiple times a day, and then compounded by years, and again, sometimes even decades of substance misuse, trust me when I tell you that the number one killer of drug users, it's not really overdose, it's stigma. Because stigma is one of the main reasons folks don't come for treatment, and it's also why they leave early. It's so bad that in 2015, only 18% of the population with a substance use disorder received treatment. And that number has not increased significantly since 2002. Now, I placed this slide at the front of this deck for a reason. And it's also why, although it was the last bullet on our objective slide, it's the first objective I mentioned. We talk a lot about stigma in our daily work. We do it at the water cooler. We know it's around us. We probably have all been stigmatized at one time or another. We've probably all done some stigmatizing. And you can almost rest assured that we've been bystanders in seeing stigma occurring in front of us. It's so prevalent that it's almost like you don't notice it around you unless it's directed to you. And I'm telling you, stigma kills. And if you remember nothing else about this presentation today, please remember that stigma is just as deadly to a person as any bag of fentanyl cut dope. And before I move off this slide, just notice that fifth bullet. They're treading water, not going anywhere, not moving forward. I want you to remember that because we're going to return to it as we move through this presentation. Now, thanks in large part to that stigma impact over the past 50 years, half the battle all of us are facing in providing treatment and recovery support, it's convincing folks we're here to help rather than to harm them. And when people with substance use disorders see messaging like what you're seeing on this slide, you can understand why. For those coping with substance use disorders or dealing with other behavioral health challenges, they're not in a big hurry to disclose this to you. The very nature of substance use treatment, until very recently, was entirely punitive. And disclosing anything about your substance use carried a risk far greater than almost anything that the drug itself could do to you. Your freedom was at stake. And well-meaning clinicians, case managers, law enforcement, court system, family and friends, even those who were supposedly there to help you overcome an addiction, we were all complicit in stigmatizing, browbeating, threatening, and forcing individuals to do things, often really unpleasant things, just to prove their worthiness to obtain other things like treatment and services and even care and concern. Here's an example. 10 years ago, when I was providing direct service to people experiencing homelessness in and around Nashville, Tennessee, to become eligible for services and housing assistance, those folks who had known drug histories, they were coerced into activities they didn't want to do and were nearly impossible to achieve. We used to tell people, you do 90 meetings in 90 days to prove to me with your signed attendance sheets that you're serious and ready, and maybe then we'll talk about housing. So I want you to think about that for just a minute, because on its face, it sounds reasonable. Show us you're serious about recovery, we'll give you a hand, but not until then. Well, the problem is that we know nothing of what their daily life is like when they're homeless, yet we're asking them to do things that are, again, almost impossible to accomplish. And this constant hypervigilance that an individual deals with when they're constantly having trauma issues, trauma responses associated with their life on the street, the potential for violence, the lack of hope, all these things. Wow. I don't know about you, but if I found myself homeless today, struggling like that, I'm pretty certain I'd be looking for things to help me cope too. Now, in this slide, there's a handout. It's called the Schilling Person-Centered Trauma-Informed Approach. So what does actually work when folks are terrified of us and avoid us like the plague, unless they're forced, usually through criminal justice involvement and a court order, to actually participate in treatment? Well, we all know and understand the importance of trauma-informed care. That's absolute. And I'm going to reinforce that here and couple it with person-centered approaches. Now, you've got a handout that should be helpful in getting a better understanding. It's called Person-Centered and Trauma-Informed Practices. But in a nutshell, with a person-centered approach, that individual is the expert on his or her life. It focuses on natural supports. It maximizes self-determination and choice. It maximizes community connection. It identifies an individual's hopes, capacities, interests, preferences, needs, and abilities. And these person-centered approaches recognize the person really as the locus of control in this web of services and supports and resources. And he or she has a choice and a voice in what's going to be done and also what won't be done. The approach is collaborative, and it's in a collaboration with a clinician and hopefully with a sort of a complementary peer specialist or recovery coach alongside that clinician. And they bring this professional experience and expertise to the table. The individual brings their personal lived experience and expertise to that discussion. But at all times, the person that is receiving the treatment is at the center of what's happening, the treatment planning, the recovery efforts, all of that. You might have heard the term, nothing about us without us. Trauma-informed, person-centered approaches honor this, and the individual is just as important on that treatment team as anybody else. So we're going to take a quick look at the rest of these components, because these approaches are really fundamental in creating a welcoming and safe space for folks who have behavioral health challenges. It doesn't guarantee that they're going to come to your doors, but if we can implement these components, we've upped that possibility considerably. Now, for this slide, there's a handout called Rask Guiding Principles. We're not going to go too deeply here because you have that handout, but essentially a recovery-oriented system of care, it's a network of organizations, agencies, and community members that coordinate a wide variety, a wide spectrum, if you will, of services and supports that help prevent, intervene in, and actually treat a substance use disorder or an opioid use disorder. And the central focus of a ROSC, this recovery-oriented system of care, is really to create an infrastructure or the actual system of care with the resources that they have to effectively address this giant range of substance use challenges that we're facing within our communities. So when we're considering a Rask, it's really important that we recognize a couple of important things. Recovery exists on a continuum of improved health and wellness. It's not a linear process. It's based on our continual growth and improved functioning. It could involve a return to use. It could involve other setbacks. Those are all natural parts of this continuum, but they're not inevitable outcomes either. Wellness is the result of improved care and balance of mind and body and spirit. It is a product of the recovery process. This recovery-oriented system of care is designed to support individuals who want to overcome their substance use issue, and they take a no wrong door to recovery approach. It provides real and independent choice among a whole bunch of different treatment and recovery options. The services should be provided in a flexible kind of unbundled package, a menu of options, if you will, that evolve over time to meet the changing needs of recovering individuals. Because what somebody needs in year 1 is radically different than what they might need in year 7 or year 22. Unfortunately, a lot of the components of a Rask, if not all of them, are often nowhere around in rural areas. And it's because of the lack of available services and resources. And I kind of like to spell that most important resource CASH, but it's a lack of available services. It's a really important consideration when we're thinking about supporting and bringing treatment to folks in rural areas and rural communities. It's going to require more effort on the part of that person, him or herself, the clinicians who are working with them, the peers who are supporting the clinicians and the individual that in question. It's a lot. And anytime I think of a Rask, I think of it as almost a trauma-informed community. And it wraps around those of us who have substance use disorders, and it supports us in a variety of ways that always go back to person-centered, trauma-informed, inclusive of family members and other allies. It provides this individualized and comprehensive service menu. And again, across the lifespan of the addiction, the system is anchored in the community. This belongs to the community. It focuses on a continuity of care, and it engages in a strength-based sort of partnership consultant relationship. It's culturally responsive to personal belief systems, and it is absolutely committed to peer recovery support services. That Rask recognizes the need for a mandatory inclusion of the voices and experiences of those who are in recovery, and really importantly, their families. It is outcome-driven, it's research-based, and it has to be funded appropriately in order for it to work.
Stephen, can I interrupt you really quickly?
Absolutely.
I wanted to let you know that the participants don't have access to the resource handout that we created. For some reason, it wasn't uploaded into the conference platform, but I've let everybody know in the chat that we will make sure that everyone receives all of the resources that you sent along for this presentation following the conference. The conference providers will give me everyone's email addresses who are attending today. Zoom keeps track of all that stuff for us, and we'll send that out to you all along with a participant survey for your evaluation purposes. So everyone just hang tight. We'll get those handouts to you following the conference.
Sherry, awesome. Thank you for that.
And Meredith also put in a link to some of them too. So.
Oh, thanks, Meredith.
Yeah.
Wonderful.
Quick work.
That's wonderful. Awesome. All right. So on this one, this is the value of peers informational brief. It's coming. I promise you. It will end up in your hands. And this one is, you want this one. It's important to recognize that peer support is an evidence-based practice, okay? It is an evidence-based practice. It's been that since, I think, 2007. And it plays a vital and central role in a recovery-oriented system of care for at least 3 primary reasons. And there's a whole bunch of other reasons, but these 3 biggies are the ones we pay attention the most to. First, mental and substance use disorders are heavily stigmatized. We know that. And a lot of folks who have these challenges have been discriminated against. Prejudice and discrimination, we know, can lead people with behavioral health disorders and their allies, their family members, their friends, to feel hopeless, to feel helpless, and really to be despairing. And when you put this against this cultural backdrop of misinformation and really, pessimistic prognoses and destructive stereotypes, this is when peer staff become invaluable, and they're concrete proof of the reality of recovery. They can instill hope that recovery is possible, and they can demonstrate by modeling that recovery to people with behavioral health conditions, their loved ones, practitioners, and the larger community, that decent and caring and worthwhile people experience psychiatric and substance use conditions. And with sufficient and appropriate support, we can recover from them as well. And second, in part due again to this, this immense amount of stigma and misinformation, the majority of people with behavioral health conditions don't seek or receive timely or effective treatment. Just 1 in 3 people with a serious mental illness is going to access any specialty mental health care. 1 in 10 with an addictive disorder is going to access specialty substance use treatment. And as living and breathing examples of recovery, peer support staff are the ones who attest to the effectiveness of treatment, of rehabilitation, and of providing that most important support. Peers are effective in engaging people into care who otherwise may not choose to even bother with it. And they act as a bridge between people in distress and what many folks, self-included, have experienced to be really an impersonal, kind of imposing, often confusing, sometimes even dangerous system. And third, by virtue of their own life experience, peer support staff will have some really valuable lessons about how to access and use behavioral healthcare services and how to manage and overcome your own behavioral health challenge. This experience enables them to act as role models for people who are just entering into or are very early in their own recovery. Peer support staff will have learned how to navigate that health and social service system that operates in your community, how to advocate for themselves within that community, how to persevere in the face of bias, discrimination, all those things happen. And in addition, they'll have learned new ways of managing and living with and recovering from those same behavioral health challenges. This experiential knowledge, it complements the clinical and technical knowledge that practitioners acquire through their training and their practice. And it offers this really important and valuable support and assistance, especially to those folks who are struggling to contend with conditions that respond in very limited ways to what we currently have for treatment. So when we think about peer support, there are 4 key functions: assistance in daily management. This is where peers use their own experience with diet, with physical activity, with medicine adherence, and helping others figure out how to manage chronic disease and some of the other conditions that we experience in our lives. There's social and emotional support. This is through empathetic listening and encouragement. Peer supporters can help individuals cope with social and emotional barriers, and they can act as sort of motivators to keep people, pushing forward to access and achieve the goals. Peers can link to clinical care and community resources, and they can help bridge this gap between individuals and health professionals and encourage them to seek out clinical support and treatment when it's appropriate. Now, peers can't say you must get treatment, but they can model and they can talk about their own recovery journey and how treatment supported them. That is hugely valuable. They can also help in identifying key resources in the community, like where to buy some healthy food, or pleasant and convenient location where you can, maybe get a little exercise in. And finally, the fourth thing that peers do, they provide this ongoing support extended over a period of time. And they successfully keep individuals engaged because they provide proactive, flexible, and continual long-term follow-up. Now, there's a handout for the MI stuff. It's called Understanding MI, August 2019, I believe. But motivational interviewing is often recommended as an evidence-based approach to changing behavior. And Miller and Rolnick, who are the motivational interview gurus, really the creator of MI, tell you that MI is a collaborative, goal-oriented style of communication with particular attention to the language of change. And it's designed to strengthen a personal motivation and a commitment to, getting to a specific goal. And they do it by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and tolerance and compassion. It's a guiding style of communication. It's really designed to empower people to change because it draws out from their meaning the importance and capacity for change. It's based on a really respectful and curious way of being with people. And it facilitates that sort of natural process of change while honoring our autonomy. And that doesn't happen a lot. It's important to understand that MI requires a clinician to engage with a client as an equal partner and to also refrain from unsolicited advice, confrontation, instructing, directing, or warning. I get it. This can be a challenge for many clinicians to initially cope with. And by the way, MI is not a way to get people to change or a technique to impose on the conversation because it takes time, it takes practice, it requires self-awareness, and it requires discipline from a clinician. And I'm just going to share really briefly. In 1998 or so, the counselor I was court ordered into used MI for me. And it was the only counselor in my entire lifetime who ever made any progress with me. And it was because he used MI. And I've not forgotten it. I'm still in touch with that same counselor 20 plus years later. And his use of motivational interviewing probably saved my life. Now, for this slide, there's a handout called Principles of Harm Reduction. And then there's a really important handout, and it is called the Overdose Prevention Strategy. And that one, I strongly encourage everybody to take a look at. It's recent. It came out through HHS and Samhsa. It's a really important read. Now, harm reduction itself, it's controversial. It's a controversial topic, and it's fighting against more than 50 years of punitive and stigmatizing and even racist drug policies that have conspired and combined to kind of destroy the lives of a lot of folks who use drugs along with their family. And a lot of times I've heard people tell me the harm caused by their addiction wasn't anything compared to the harm that was caused by their involvement in the criminal justice system. And when we consider that nearly 70,000 people died from a drug overdose last year, the work of harm reduction movement has to be viewed today as a matter of life and death. So what is it? Well, it's a set of practical strategies and ideas that are aimed at reducing the negative consequences associated with drug use. It's also a movement for social justice, and it's built on a belief in and respect for the rights of people who use drugs. I recognize how difficult it is to swallow that. It's particularly after the last 70 plus years of the war on drugs. But the new 2021 HHS, Health and Human Services Overdose Prevention Strategy, identifies harm reduction as a key priority area. Harm is not an inevitable consequence of drug use, and it can be prevented and it can be reduced through a range of strategies. We know that harm reduction incorporates this spectrum of strategies that target folks who use drugs, and it includes safer use and managed use. Abstinence is within harm reduction. It's not in the recovery definition, but it is in the harm reduction definition. Meeting people who use drugs where they're at and addressing the conditions of use along with the use itself. Because harm reduction demands that interventions and policies designed to serve people who use drugs reflect specific and individual and community needs, it's really hard to get a universal definition or a formula for how harm reduction is going to operate or be implemented in your community. But the Harm Reduction Coalition, there's 8 principles that they've identified for harm reduction. Because drug use is part of our world, we choose to minimize its harmful effects rather than to simply ignore or condemn them. We acknowledge that some ways of using drugs are clearly safer than others. We base our criteria on the quality of individual and community life and well-being. We provide non-judgmental, non-coercive provision of services and resources. I get it, that's a tough one. Non-judgmental, non-coercive provision of services. We ensure routine and authentic voices of those who use drugs. We affirm drug users as the primary agents of reducing the harms of their own use. We recognize the realities of poverty, of class, of racism, of social isolation, of trauma, all impacting drug use. And we do not minimize or ignore the harm and the danger that is associated with licit and illicit drug use. Now, you're going to hear more. You're probably going to hear a lot more about harm reduction approaches in the very near future, because as I mentioned, HHS and Samhsa have included this as one of the 4 key priority areas for an overdose prevention strategy. That strategy reflects HHS's long-term commitment to promoting harm reduction across its programs, and it extends recent HHS harm reduction efforts like Samhsa and the CDC's April 2021 announcement. This was like earth-shattering. Certain federal grant funds can be used to purchase fentanyl test strips, which some people use to avoid or to take additional precautions when using drugs that possibly have been adulterated with fentanyl. And HHS recognized the need for additional work to mitigate the risks that are associated with drug use. This priority supports further expanding access to a broader array of harm reduction interventions and better integration of harm reduction principles and practices right into specialty SUD treatment and even general medical care. This overall strategy, it's supported by several guiding principles: equity, data and evidence, coordination, collaboration and integration, and importantly, reducing that stigma and the bias. And HHS has also come up with a set of objectives, and I think this is awesome that they have objectives specific to harm reduction. Advance research and demonstrations on innovative harm reduction approaches, promote evidence-based harm reduction services, including those that are integrated with healthcare delivery, expand sustainable funding strategies for harm reduction services. Let me repeat that. Expand sustainable funding strategies for harm reduction services. That is major. Develop educational materials and programs to reduce stigma. Folks, harm reduction is likely here to stay, and its value is huge. Good grief. There's so much to talk about around medications to treat an opioid use disorder. I really had to be careful not to overwhelm everybody. And frankly, my hope here is that you all are aware of the efficacy of MAT. Again, evidence-based approach. It is the best treatment we have for opioid use disorder. But nearly 80% of folks who have an OUD don't receive it. And I'm going to say it again, one of the top reasons they don't, because stigma. We know opioids will kill. So does stigma when it keeps us from accessing treatment. medication-assisted treatment, it's an effective response to opioid use. It's the use of medications in combination with behavioral therapies that provide a whole person approach to the treatment of this substance use disorder. Individuals who receive MAT often demonstrate improvement in addiction-related behaviors and psychosocial functioning almost immediately. Now, I'm not going to spend any time diving into the actual medications here or their mechanisms of action. You have a pocket guide that will provide all of that information. But the most important thing I can share with you about MAT is that it saves lives, it fosters recovery, and folks, it ends the insanity of the untreated opioid addiction. And when I say insanity, I mean, this is a level of insane that very few people who haven't experienced it can understand. It is insanity. And if we couple it with solid recovery supports, wow, this treatment works. And the one thing I'll leave you with regarding MAT is that sometimes there are folks who find that they need to be on MAT for a very long time, sometimes even permanently. It's always their decision. It's always an individual's decision. There should never be any pressure or hints or efforts to force a person to stop MAT before they themselves believe they're ready. This is always their decision, and it really cannot be anybody else's. Now, for this particular slide, there's a couple of handouts that will come with it. They have the same names, basically. Words matter, language choices reduce stigma, and the words we use matter, reducing stigma through language. Everybody, regardless of sex, age, race, or ability, we deserve to be treated with dignity and respect. And as part of the effort to end discrimination, segregation, stigma, racism, in employment, education, and really our communities at large, it's important that we start eliminating prejudicial and stigmatizing language whenever we encounter it. Because words matter, and they matter a lot, and they label, they might explain, but they create perception, and they can create a misperception too. And they can hurt, they can limit, and they can also lift. They can convey very powerful and long-lasting messages. Person-first language, this is an objective way of acknowledging, communicating, and reporting on disabilities and conditions. It removes generalizations and assumptions and stereotypes because it focuses on the person rather than the illness, the condition, the disability, or the disease. Now, there's a larger discussion around whether individuals want to use person-first or identity-first approaches. And person-first language, like a person with a disability, is largely considered the default or the most respectful terminology to use because it puts the person in front of that disability. It's a way to separate somebody's diagnosis from who they actually are. For those supporting the identity-first approach, it's an effort that centers on disability while still recognizing personhood. Identity-first language was born out of the disability pride movement, and they argued that a disability is really nothing to be ashamed of. Individuals with disabilities, they referred to this approach as a disabled person. And they prefer this identity-first language because they often think that person-first language furthers the notion that having a disability is shameful. They ask, why do you have to separate somebody from their disability in order to see them as a person? That's a pretty good question. And they argue the phrase disabled person still has the word person in it, and you don't truly see them if you don't acknowledge their disabilities. All this to say, words matter. They matter a lot, and there's a lot of research available that confirms the impact and the discrimination that can occur in really almost seemingly insignificant ways. The difference between using person is a substance abuser instead of person with a substance use disorder was much more likely to be viewed and treated in a punitive manner, where the person with the substance use disorder receive more compassionate interactions, care, and support. I'm telling you, words matter, and they matter a lot. Now, for this particular slide, there's two handouts. One is the cultural competence continuum, and the other one is around cultural humility. And health and human service organizations, I think, are really getting the understanding that there's a need for us to really enhance our services around cultural and linguistic needs of some really diverse populations. So what is cultural competence? And I don't even like the term competence. I really feel it's probably more appropriate to say cultural proficiency. And there's not one definition, right? Culture refers to integrated patterns of human behavior. It includes language and communication, actions, customs, beliefs, values, institutions of racial, ethnic, religious, social groups. Competence implies having the capacity to function effectively as an individual and an organization within that context of those cultural beliefs, those behaviors, and the needs that come to us through those trying to access our services. Basically, you can define cultural competence as the ability to understand and appreciate and interact with folks from cultures or belief systems that are different than your own. So what then is cultural humility? Well, at its base, cultural humility means opening up a conversation in a way that attempts to understand a person's identity related to race, ethnicity, gender, sexual orientation, socioeconomic status, education, social needs, etc. To do that, an awareness of the self is really central to the notion of this cultural humility. Who a person is informs how they see somebody else. So what does that mean? Well, where cultural competence faces outward and it focuses on the other, cultural humility turns that lens inward, and we look upon ourselves, because an awareness of the self is really central to the notion of cultural humility. That awareness, it may come from questions like, and these are all self-reflecting, what part of my identity am I aware of? And what are those parts that are most notable and noticeable to others? Which parts of my identity might be privileged or marginalized? How does my sense of identity shift based on the context and the settings I find myself in? What are the parts onto which people project, and which parts get received well, and who receives them? What might be my blind spots and my own biases? Now, when we have this awareness, we can ask questions about how a provider might receive and interpret their client. Who is this person? How do I make sense of them? What knowledge and awareness do I have about their culture? What thoughts and feelings arise in me about them? Now, there's a crucial way that we build cultural humility into a healthcare system. We do it with representation, because a diverse workforce, it's essential, but it doesn't just stop there, because truly multiculturally attuned providers upholding the values of cultural humility and that cultural proficiency, promoting health equity, and improving the access to care, it necessitates that clinicians understand how all these isms are operational within the very systems that we're providing services within. And for this, that cultural proficiency and humility, along with sensitivity trainings, they're really essential. Now, on this one, there are two handouts, a rural community action guide, and then there's a rural challenges issue brief. Today, pretty much every community we have has been affected by drug addiction. And as the prevalence of SUD and drug overdose deaths continue to rise, especially in rural areas, we can't see drug use anymore as an urban or inner city issue. It is impacting individuals across all socioeconomic groups. And at times it dramatically changes the image of a person with SUD. Sometimes, someone struggling with an addiction today, That person could be a working mother, a senior citizen, a pastor, a coach, a high school athlete, a college student. If we want to improve SUD outcomes and then build strong and healthy communities, rural leaders in particular are going to need to think about and change how they understand, talk about, and respond to addiction. This very fundamental shift, it often begins just with understanding the face of addiction. And all that means is who is impacted by SUD in my community and how. And I get it, this can be a really hard pill to swallow for some, but who are they? How did they get there? And how do we support them? And in addition to understanding that face, there's a bunch of other challenges that conspire to make service delivery and access to that delivery really difficult. Sometimes it doesn't even exist. So it's stigma. It's limited funding for recovery residences and for recovery supports and services. We know there are transportation challenges in rural areas. There's limited access to a continuum of care and of a recovery-oriented system of care. We don't really have a lot of detox facilities, hanging out in the back 40. There's hardly any wraparound services. And often it's very limited access to private and public health assurance. And, I'm bringing us back to stigma and bias again, too. Those two are two of the biggest challenges in rural areas, stigma and bias. And there is evidence that shows that the higher the stigma level is in a community, the more likely it is that treatment options will be less. Why would you provide treatment for anybody that is, so stigmatized that you don't feel like they even belong in your community? Stigma has a lot of power. The scope of its impact can really be, I think, best understood by personal stories and then the data that we can bring around the impact of substance misuse. To get both, we got to ensure folks are going to talk about it, and they're going to do that in an open and honest way. But stigma silences most of us, and those potential voices that we might be able to get. The bummer is there's provider bias, and it reinforces the idea that those clients just ain't interested in recovery. Yeah, they are. We're not bringing it to them in a way that they understand. The onus is on us. And unfortunately, stigma silences many of those voices. Again, and when we reduce stigma and bias, there's a collective understanding that's built over time that community leaders are going to be better able to recognize the signs of addiction in their community. And when they can recognize that, they'll be able to expand some efforts to deconstruct the stigma surrounding it and concurrently try to increase both the community understanding and tolerance around substance use disorders, as well as providing some access to services and a reduction in the barriers that folks in rural areas are finding. So, if what we're trying to do is get beyond where we find ourselves today, particularly in rural areas, we better be paying close attention, and we better have, kind of our eye looking at finding some solutions to things like stigma. My initial thought here was to apologize for listing it again, but folks, it's one of the primary reasons we don't come for treatment, and it's why we leave treatment early, and it's also why families want to keep people in their family with a substance use disorder quiet. They don't want to talk about it. Economic and tech limitations in a lot of rural areas, the job prospects, particularly for those folks who are struggling, non-existent. There's a limited access to transition and long-term housing. This probably doesn't need a whole bunch of explanation. There's a lack of anonymity. There's misinformation and disinformation. In a small rural community, everybody knows everybody. There's limited access to even 12-step mutual aid meetings. It leaves us feeling isolated and alone and struggling with misinformation. Limited access to employment, lack of a mental, dental, and health services. All these things happen. And then, of course, bias, and we all carry it. And it's important we're aware that it exists, and it exists unconsciously. So you could be exhibiting biased behavior, and you won't realize it, and your client will. And it's why he or she is no longer your client, or they don't come to you for assistance in the first place. Stigma is one of the major roadblocks that keep people from seeking and accepting treatment. And it's also one of the primary reasons we leave early. I know I've said that over and over, but stigma kills. Now, there's two more handouts, and this one is the ACE assessment tool and the consequences of ACEs, excuse me. Now, as I prepare to close this, this virtual journey that we've all taken together, it reminds me of a lot of other journeys that I've taken in my own life, and in particular, the journey that got me kind of to my destination in front of all of you. So remember when I told you earlier that MAT is the best evidence-based treatment we have for opioid use disorder, but about 80% of individuals with an opioid use disorder don't request or come after the treatment. And remember when I shared that stigma slide at the start, and I told you to remember that fifth bullet because we'd come back to it? Now, if your memory is anything like mine, you're going to need a reminder. Well, here's what that bullet said. People using MAT are just treading water. They're not going anywhere, and they're not moving forward. So in 1997, I was court-ordered into a 12-step program. It was part of my parole after I'd been arrested for a nonviolent cannabis crime, and I was sent to prison for a couple of years. That state where that happened, that isn't a crime anymore. I was, at the time, however, living homeless. I was couch surfing. I was seriously addicted to black tar heroin, and I was trying to cope with an undiagnosed complex trauma. My ACE score is 9, and I provided you a handout on adverse childhood experiences in case you're not aware of what an ACE score is and what it means. I was also coping with a serious mental illness. It includes a bipolar 2 disorder, severe ADHD, and PTSD. And I coped with all of them the only way I knew how at the time, better living through chemicals, most of which were and still are illegal. I've been trying to kick a heroin habit for years, but like 90% of my brothers and sisters fighting an opioid use disorder, I couldn't do it through abstinence only, even in spite of Herculean efforts to do so. Now, we know today this is a common theme for those of us with OUD, but back in the 90s, trust me when I tell you, I felt like a failure because I couldn't stop using, and the 12 steps didn't work for me. And by the way, for those who think that incarceration is going to keep us away from the drug supply, the strongest heroin I ever did, I obtained in prison. And the supply chain there, far more dependable than anything I found on the outside. And during this time of active addiction, I'd also been purchasing diverted street methadone when heroin was hard to find. And I discovered that unlike heroin, lasted for a long time and I could function on it. All this to tell you all that for me, stigma nearly killed me, and it nearly killed me 3 times. I overdosed 3 different times when I struggled with the stigma around initiating MAT. But I am one tough SOB, and I will be damned if I'm going to die because of how somebody else viewed my behavior. So after my 3rd overdose, my partner took me to the clinic and said, "You will start this or I'm leaving." And I can assure you, if mama ain't happy, nobody's happy. So I listened to my partner. I went to a clinic. I got inducted on methadone. When I started MAT, within the first hour, I was well. My cravings disappeared, and also my cravings for other substances. The day I started MAT, I stopped all other illegal drug use. And over the next 2 years, I finished a bachelor's degree. 3 years later, I finished a master's degree, and I was working for a small college as the director of development. A couple of years after that, I was the #1 street outreach specialist in Nashville, Tennessee. I co-founded a street newspaper here that's the largest selling street newspaper in the world. I am the poster child for the good that comes with recovery, And it's why I'm here in front of all of you today. Because the next time you hear that those folks on methadone or buprenorphine are just treading water, I want you to remember my story, the value of my experience and the power I exhibit when I share it and change people's minds and their perceptions on the efficacy of medication-assisted treatment and the value of recovery. Because we can and we do recover. Some of us need medication, some don't. And when we do recover, regardless of the pathway that we choose, we go on to do great things in our lives, our families, our relationships, and our communities. I'm sorry for taking us a couple of minutes over, but I am so grateful just for the opportunity to share. A huge thank you to Sherry Watkins for asking me to come and for all of you for putting this on. Thank you so much for just listening to me. Woo! Appreciate it.
Thank you so much, Stephen. That was amazing. Lots of great comments. They'll be added to the platform chat, so you'll be able to read those. And thank you so much. It's always so inspiring to hear people's stories. And you really gave us a lot of good information. And like Sherry said, we will be sending out those handouts that you didn't have beforehand. So you'll have those to use too. Plus we put a lot of the links, thanks to some of you that are in attendance for putting those in the links so we can get to them. So thanks so much for attending. And we have one more keynote speaker coming up. So that starts in about 13 minutes now. So thanks for joining us.
Happy Wednesday, everybody.
Stephen, thank you so much. That was
my pleasure.
Awesome. Amazing.
Thank you. It's really my pleasure.
Yeah. Thank you for agreeing to speak to us today.
Absolutely. Thank you for listening. That's the better part. See you.
Well, you made it easy to listen. So.
Oh, wonderful. Thank you, Joy. And I hope you guys have a lovely and productive afternoon. Thanks
you
again.
too. Have fun mowing that lawn in the nice weather there.
That's where I'm headed. Thank you. See you guys.
Bye-bye. How many?